Welcome back to the deep dive. Today, we're tackling a huge topic, orthopedic anesthesia. We've got a massive stack of sources here, and our mission is to really distill it all down. We want to get you to a master level understanding of this incredibly dynamic and honestly high stakes field.
It really is high stakes. And specialization is key because the range of procedures in orthopedics is just extraordinary. You need to be so adaptable.
Right, like what kind of range are we talking about?
Think about this. You could start your day with a tiny infant, maybe needing an Achilles tendon lengthening for clubfoot. Very delicate, specialized pediatric pharmacology involved there.
Okay, tiny baby. And then next.
But maybe you shift to an adolescent, perhaps someone with Duchenne muscular dystrophy, needing a massive spinal fusion. Huge surgery, minimal cardiopulmonary reserve. A completely different challenge.
Wow. And I guess the other end of the spectrum, too.
Absolutely. The very next room could have an octogenarian, maybe 80, 90 years old, who fell, broke a bone, and needs an intramedullary nail. So you're covering the entire human lifespan, infancy, right through to, advanced age. That's why you need that deep grasp of physiology and all the potential comorbidities.
It's fascinating. And the name itself, orthopedics, it has ancient roots, doesn't it?
It does. Comes from Greek orthos, meaning to straighten, and paideia, nurturing of children.
Yeah.
Fits that historical context.
And we've seen evidence way back, right? Ancient Egyptian splints, even interventions for Roman gladiators.
Exactly. But while the history is long, the modern practice is defined by incredibly rapid change. Constant evolution.
What kind of changes are we seeing now?
Oh, huge shifts. Think about ultrasound-guided regional anesthesia that's become standard practice relatively recently. Sophisticated techniques to minimize opioids. Plus innovations in biologics, even 3D printing for custom joints. It means clinicians have to be committed to lifelong learning.
Okay.
It's not really optional anymore if you want to keep up and ensure safety.
And all this innovation is happening against a backdrop of, just massive demand, isn't it? The aging population is a huge factor.
Huge. The sheer volume is reshaping everything. Our sources really underscore this. Let's look at some numbers we pulled together.
Okay, lay 'em on us.
Right, so back in 2014 in the U.S., there were about 370,770 primary total hip arthroplasties, THAs, and primary total knee arthroplasties, TKAs, were around 680,150.
Okay, big numbers already, but the projections.
The projections for 2030 are, frankly, staggering. Primary THA expected to jump to somewhere between 635,000 and maybe even over 900,000 procedures a year.
Yeah.
And primary TKA knees could potentially hit 1.67 million. That's potentially more than double in just over 15 years.
That's unbelievable volume, and that must have knock-on effects for revisions, too.
Absolutely. Critical point. When primaries surge like that, revisions inevitably follow. Between 2014 and 2030, revision THA is projected to climb 43% to 70%, and revision TKA could soar by 78% to a staggering 182%. We're not just talking growth. This is an explosion in demand for complex, high-risk, technically difficult surgeries.
So that massive growth really sets the stage for the anesthetic complexity. When you're planning anesthesia, general, regional, maybe a mix, you're juggling a lot of factors.
It's a constant balancing act. You're considering the exact surgery, how long it'll take, what the patient wants, what the surgeon prefers.
Any tricky anatomy, like a difficult airway or challenging positioning.
Definitely. Plus, a thorough assessment of all their existing health problems, their comorbidities, and, crucially, how fast and how well you want them to recover afterwards. It's truly an individualized plan for every single patient.
Okay, let's start unpacking that complexity. We need to understand the diseases driving this surge first, right? Let's dive into the big ones, starting with osteoarthritis, OA. And why the old name isn't quite right.
Right, OA. It's the most common joint disease worldwide, hands down. The #1 reason people get joint replacements. The economic cost alone tells you how widespread it is, something like $81 billion a year in the U.S., maybe 1 to 2.5% of GDP in many developed countries. It's a massive societal issue.
And you mentioned the name. Why is degenerative joint disease considered a misnomer now?
Because it's too simple. It implies just wear and tear, but the reality is much more complex. It fails to capture the local and systemic inflammatory processes involved. There's an active inflammation happening.
So it's not just passive breakdown, what's actually going on in the joint.
You get erosion of the cartilage, obviously, but also formation of osteophytes, those bone spurs. Hits hips, knees, hands, spine, feet most often. And we now understand the subchondral bone, the bone right under the cartilage, is a major source of the pain people feel. It's not just the cartilage loss.
And the inflammation part.
That involves the synovium, the lining that lubricates the joint. You
Uh,
get synovitis, inflammation of that lining, which persists throughout the disease.
Okay, and risk factors, age, obviously.
Yes, age over 60 is a big one. Female sex. Repetitive movements, like certain jobs or sports. And obesity is interesting. It's not just the extra mechanical load.
What else does obesity do?
Obesity promotes the release of adipokines from fat tissue. These are bioactive molecules that actually contribute to the chronic inflammatory state within the joints. So it's a chemical effect too.
And genetics plays a role.
It does, though it seems to influence the severity more in hip and spine OA compared to hands or knees.
So from an anesthesia perspective, with OA, we're essentially managing the fallout, the pain, the damage, because there aren't really drugs that modify the disease itself yet.
Exactly. Unlike some other conditions we'll talk about, there are no disease-modifying drugs, DMDs, for OA currently. When non-surgical options fail, joint replacement arthroplasty is the end-stage solution.
Okay, that leads us nicely into rheumatoid arthritis, RA. This is a different beast entirely, right? Systemic autoimmune.
Completely different. RA is much more aggressive. You see joint swelling, tenderness, actual destruction of the joint, chronic pain, severe mobility limits. It affects about 8% of women and 5% of men over their lifetime.
And diagnosing it. We're getting better at catching it early.
Yes, definitely. Autoantibodies can often be detected months, even years, before symptoms show up in maybe 80–90% of patients. The 2010 classification criteria help finding synovitis in even one joint, plus having the blood tests confirm it. Early diagnosis means early treatment to try and slow that destruction.
What about triggers? We know genetics is involved, but environmental factors.
Big ones. Smoking is huge. A 20-pack-year history gives you a very high risk, although quitting for 10 years brings the risk back down somewhat. Obesity again. And interestingly, periodontitis, gum disease.
Gum disease, how does that connect?
There's a specific bacterium, Porphyromonas gingivalis, often found in severe periodontitis. The theory is that bacteria or their inflammatory byproducts might trigger or amplify the autoimmune response that underlies RA. It really highlights that RA is a whole-body inflammatory disease.
And that's where the major anesthetic challenges come in, isn't it? Because it's systemic.
Precisely. Let's do that deep dive. With RA, the number one anesthetic concern is often the airway.
Okay. Why the airway specifically?
Potential problems in 3 key areas. First, the cervical spine. Rheumatoid nodules and inflammation can cause instability, particularly at the lanolaxial joint right at the top of the neck.
Second.
The temporomandibular joint, the TMJ-RA, can severely limit how far someone can open their mouth, which obviously makes laryngoscopy and intubation very difficult, maybe impossible.
And the third area? You said this was the most dangerous?
Yes, the larynx itself, specifically the cricoarytenoid joints. These tiny joints control vocal cord movement. RA can cause nodules and inflammation here, and the devastating result can be the vocal cords getting fixed in the closed or adducted position. This can lead to sudden, severe airway obstruction, especially when the patient is waking up from anesthesia.
That sounds terrifying. So a meticulous pre-op airway exam checking neck movement, mouth opening is absolutely critical for RA patients.
Non-negotiable. Any neck pain or neurological symptoms with movement need careful evaluation. And you have to remember, an airway that seems okay pre-op might become unstable during the case due to positioning or inflammation.
And we can't forget the heart either. Our sources mention cardiovascular disease is the top cause of death in RA.
That's right. It's likely linked to that chronic systemic inflammation driving accelerated atherosclerosis, hardening of the arteries, even if they're taking NSAIDs. So a thorough cardiac workup before major surgery is essential.
Okay, moving from RA to another inflammatory condition, ankylosing spondylitis, AS, the rigid spine. If RA brings airway mobility issues, AS sounds like structural rigidity is the main problem.
Exactly. AS is also inflammatory and autoimmune, but it primarily targets the spine and the sacroiliac joints. And it's about twice as common in men.
What's the long-term effect on the spine?
It's structurally devastating over time. You get remodeling of the spinal column, bone formation where it shouldn't be, fusion of vertebrae, producing that classic bamboo spine look on x-rays. This leads to a progressive, severe, fixed kyphosis, that forward hunch, and also generalized osteoporosis. So the spine is rigid, but also brittle, very prone to fractures from minor trauma.
How does the pain typically present? You mentioned inflammatory back pain.
Right. It's different from typical mechanical back pain. Key features, and usually patients have 2 or more of these, include morning stiffness lasting over 30 minutes, pain that actually gets better with activity, not rest, pain at night that wakes them up, especially in the second half of the night, and sometimes alternating buttock pain.
So the critical anesthetic challenge here must be the airway again, but for different reasons. Extreme neck stiffness, potential fusion.
Absolutely. Airway management in severe AS requires extreme caution. The primary strategy really should be awake intubation,
Why awake?
because any manipulation of that rigid fused neck, even the slight extension needed for standard laryngoscopy, carries a huge risk of causing a fracture, potentially leading to spinal cord injury. It's just too dangerous to force it.
Are there other options if the neck isn't completely fused?
Yes, if it's less severe, video laryngoscopes can be very helpful. They often provide a better view with less neck manipulation compared to traditional direct laryngoscopy. Success rates can be higher.
And like ARA, AS has systemic effects beyond the spine.
It does. There's an increased cardiovascular risk. Aortic insufficiency can occur, conduction defects are common, and AV block is the most frequent arrhythmia seen. Also, the chest wall rigidity can eventually lead to restrictive pulmonary disease, though interestingly, standard lung function tests might look normal initially because the diaphragm compensates. So you have to be aware of the potential even if PFTs are okay.
Okay, we've covered these major chronic diseases, OA, RA, AS. Now, let's layer on the age factor. What happens when these conditions meet the geriatric patient?
That brings us squarely to the concept of frailty. And the demographics here are just mind-blowing. By 2050, the number of people over 65 in the U.S. is expected to be over 83 million, more than double what it was in 2012.
And this group uses more healthcare and, critically, has much higher risks for surgical complications, disability, death.
Exactly. And frailty isn't just being old, it's a specific syndrome. It's about reduced homeostatic reserve, the body's ability to bounce back from stress. It affects physiology, cognition, social well-being, everything. This lack of reserve makes patients incredibly vulnerable.
It seems vital to quantify that vulnerability, but standard things like the ASA score, they're pretty subjective, aren't they? Not really designed for predicting specific post-op outcomes in the elderly.
That's the issue. The ASA score reflects comorbidities, but not necessarily this overall vulnerability. That's why validated tools are so important. The Modified Frailty Index is one common example. It's derived from a longer assessment, but helps predict poor outcomes specifically in surgical patients.
So how do we spot frailty clinically? What's the frailty phenotype?
It's generally defined by having 3 or more of 5 criteria. These are muscle weakness, like poor grip strength, slow walking speed, self-reported exhaustion, low overall physical activity levels, and unintentional weight loss.
So if you see someone looking weak, walking slowly, saying they're tired all the time, not doing much, and maybe losing weight, that's the picture.
That's the picture you should be looking for, yes. It suggests that underlying lack of reserve.
And physiologically, what's driving that? What's going on underneath?
It seems to be driven by a chronic, low-grade inflammation. You see elevated levels of inflammatory cytokines, things like interleukin-6, C-reactive protein, TNF-alpha. This constant low-level inflammation promotes catabolism.
Meaning the body breaks itself down.
Exactly. It breaks down skeletal muscle, leading to that weakness and slow walking speed. It also breaks down fat tissue, cause of the weight loss. This inflammatory state is essentially dismantling the body's reserves before surgery even starts.
Which links directly back to orthopedics. Frailty obviously connects to heart disease, insulin resistance, but the big one here is falls, right?
Huge connection. And we need to think about different types of falls. There are hot falls related to a minor illness like a UTI that temporarily throws off balance. But then there are spontaneous falls where someone falls just doing something simple like standing up because those vital postural systems are failing. Assessing frailty is crucial because often preventing these falls is the reason for the orthopedic surgery in the first place.
Okay, so we have this picture of the patient population, young to old, often frail, carrying these complex diseases. Now let's move into the OR. Let's talk procedures, techniques, and their specific complications, starting with arthroscopy.
Right, arthroscopy. Minimally invasive, common for knees and shoulders. But the big issue here, often underestimated, is fluid management.
Because you need to inflate the joint to see using bags of fluid under pressure.
Exactly. Large bags, 3 to 5 liters sometimes, of irrigation fluid are pushed in to distend the joint space. The risk comes if the inflow isn't balanced by the outflow, especially in longer procedures. The patient can absorb a huge amount of that fluid systemically, leading to volume overload, potentially congestive heart failure, pulmonary edema. It can happen quickly if you're not watching the fluid balance meticulously.
And if they use sterile water instead of saline.
Then you add the risk of acute hyponatremia, a dangerous drop in sodium levels on top of the volume issues. Constant communication between anesthesia and surgery about fluid in versus fluid out is absolutely essential.
For shoulder arthroscopy specifically, there's another layer of risk beyond just fluid, right? Related to air or pressure.
Yes, particularly with shoulder scope in the beach chair position, or during procedures like subacromial decompression where powered instruments and high-pressure irrigation are used, you can get subcutaneous emphysema air under the skin, or worse, pneumomediastinum air in the chest around the heart, or even a tension pneumothorax. Air or fluid can track along tissue planes into the chest.
And recognizing a tension pneumothorax needs to be instant. What are those key signs again?
Sudden, unexplained drop in oxygen saturation, high heart rate, maybe a high CVP if monitored, potentially absent breath sounds on one side, and in severe cases, the trachea might shift away from the affected side. You have to act immediately to decompress the chest.
Okay, shifting gears to the big joint replacements, total hip, THA, and total knee, TKA, and the specific risk of cement.
Right. With THA, the surgical approach matters a bit for planning. You have the traditional posterior approach, bigger incision, but the direct anterior approach, DAA, is increasingly popular.
Why DAA?
It's muscle sparing. Recovery tends to be faster, potentially shorter hospital stays, but it's technically trickier for the surgeon.
Regardless of approach, for THA, you often need good muscle relaxation, right? For
Yeah.
dislocating the hip.
Exactly. Which makes regional anesthesia, particularly a spinal block, a really good, often preferred choice. It provides excellent operating conditions.
But then comes the cement, bone cement, and the risk of bone cement implantation syndrome, BCIS. Let's dive deep here. What is BCIS?
BCIS is a sudden, potentially catastrophic physiological collapse. The classic signs are abrupt hypotension, hypoxia, low oxygen, cardiac arrhythmias, a sharp rise in pulmonary vascular resistance. And importantly, if the patient's awake under regional, they might suddenly lose consciousness. Or, in the worst case, cardiac arrest. It's a true anesthetic emergency.
When does it typically happen? What are the trigger moments during surgery?
It most commonly occurs during periods of high pressure within the bone canal. So things like reaming the femoral canal, actually injecting the cement under pressure, inserting the prosthetic stem into the cement, and also sometimes upon deflation of the limb tourniquet, particularly in knee replacements, as emboli trapped below the cuff get released centrally.
What's the mechanism? Why does pressurizing the bone cause this systemic collapse?
When that methyl methacrylate cement is forced into the prepared bone, the pressure skyrockets. This physically shoves fat globules, bone marrow debris, air, maybe even tiny bits of cement, into the open venous channels within the bone. These emboli travel directly to the right side of the heart and then get pumped into the lungs, obstructing the pulmonary circulation. This causes acute right heart strain or failure.
So the management has to be immediate and targeted at supporting that failing right heart.
Absolutely.
Yeah.
As soon as cement goes in, everyone needs to be hyper alert. Management is critical. Crank up the oxygen to 100% IO2, give fluids aggressively to maintain preload to the right heart, and use potent alpha agonist pure vasoconstrictors like phenylephrine to counteract the hypotension caused by that sudden increase in pulmonary vascular resistance. Communication is key.
Okay, TKA carries similar cement risks, plus often involves tourniquets. Let's talk more about regional anesthesia for extremities, foot and ankle surgery.
Excellent candidates for a regional. You could do a spinal or often combine nerve blocks like a sciatic nerve block, plus maybe a femoral or popliteal block, depending on the exact surgery. Good regional blocks can often provide enough anesthesia for surgery below the knee for up to 2 hours without even needing a thigh tourniquet, which avoids tourniquet pain and other issues.
And for shorter things, hand or forearm surgery.
Often ideal for regional too. Ultrasound-guided brachial plexus blocks are very common and effective. Or, for some shorter procedures, an IV regional block, the beer block, is an option.
Ah, the beer block. Simple, but carries a specific, serious risk, doesn't it?
It does. The big worry with a beer block is local anesthetic systemic toxicity elast, because you're injecting a relatively large dose of local anesthetic into the arm or leg vein and relying entirely on a tourniquet to keep it there.
What happens if that tourniquet fails or is let down too soon?
You get a sudden bolus of local anesthetic hitting the systemic circulation. The dosage thresholds for toxicity are surprisingly low. Seizures can happen with as little as 1.4 mg/kg of lidocaine, and cardiac arrest is a risk around 2.5 mg/kg.
And the onset might not be immediate?
That's the other danger. Symptoms of LAS can be delayed, sometimes appearing up to 60 minutes after the block is placed or the tourniquet comes down, so you need prolonged vigilance. Watch for early signs like numbness around the mouth, metallic taste, tinnitus, even during the case.
Okay, let's shift to the spine. Spinal surgery. Here, positioning isn't just awkward, it's a major potential source of harm.
Absolutely. Spine surgery, whether it's for common things like herniated discs or spinal stenosis or major deformity corrections like scoliosis, almost always involves putting the patient in the prone position, face down, and often for many hours.
Techniques vary, right? From standard laminectomies to complex fusions and now more minimally invasive stuff.
Yes, things like percutaneous endoscopic lumbar discectomy are becoming more common, but even those often require prone positioning.
And some cases, like major scoliosis surgery, might even need an anterior approach through the chest.
Right, if they need an anterior approach, maybe via thoracotomy, the patient's positioned laterally on their side. That requires one lung ventilation using a double lumen tube, which is a whole separate anesthetic challenge managing ventilation and oxygenation.
But let's focus on the prone position, which is so common for posterior spine surgery. You mentioned special frames or rolls.
Yes, using things like a Wilson frame, Relton frame, or an Andrews table is mandatory. The goal is to allow the patient's abdomen to hang completely free without any compression against the table surface.
Why is that abdominal freedom so critical? What goes wrong if it's compressed?
Compression of the abdomen significantly increases both intra-abdominal pressure and intrathoracic pressure. This impedes venous return to the heart, which can lower cardiac output. But, crucially for the surgeon, it also causes engorgement of the epidural veins, the network of veins around the spinal cord.
Which means more bleeding.
Exactly. Significantly more bleeding during the surgery. Makes the surgeon's job harder, increases risk, increases transfusion needs. It's preventable with proper positioning. Plus, the prone position itself tends to increase systemic and pulmonary vascular resistance, so adequate fluid resuscitation is key.
What about protecting the brain and nerves? Head alignment in the prone position seems critical. You mentioned vertebral artery compression.
Yes, this is a vital point. If the head is rotated excessively to one side, you can compress the vertebral artery on the opposite side. Studies show that rotation of just 60 degrees can start to impede flow, and 80 degrees might completely occlude it. This compromises blood flow to the back of the brain.
So the rule is,
the head must be kept in a neutral anatomical position. No excessive rotation, flexion, or extension. And ideally, the head should be level with, or slightly higher than, the heart.
why level with or above the heart?
That promotes venous drainage away from the brain and head, preventing congestion. It also helps avoid direct pressure on the eyes or orbits. Those old-fashioned horseshoe headrests that could put direct pressure on the eye socket, definitely discouraged now.
Because if positioning goes wrong, especially with prolonged prone cases and maybe large blood loss, you risk the devastating complication of postoperative visual loss, POVL.
POVL is thankfully rare, but catastrophic when it happens. It generally falls into two categories. One is retinal vascular occlusion, usually from direct pressure on the eyeball cutting off its blood supply. The other, often more common in spine surgery, is ischemic optic neuropathy, ION.
How is ION different?
ION is thought to be caused by inadequate blood flow, or ischemia, to the optic nerve itself. It typically presents later, maybe 24 to 48 hours after surgery. It's usually painless and often affects both eyes. It's more insidious than direct pressure injury.
What are the big risk factors for ION that we need to watch out for?
Male sex seems to be a risk factor, possibly related to hormonal differences, though the exact reason isn't clear. Obesity. Using certain positioning frames like the Wilson frame, long anesthesia duration over 6 hours is often cited. Significant blood loss during the case. And interestingly, how fluids are managed using a lower proportion of colloid fluids relative to crystalloids has been implicated.
The ASA has specific recommendations to try and prevent POVL, right? What are the key takeaways there?
Yes, the task force guidelines are crucial. They emphasize informing high-risk patients about the possibility. Intraoperatively, continually monitor blood pressure. Try to keep it near the patient's baseline. Keep the head neutral and level with or above the heart. Use colloids as part of the fluid replacement strategy, not just crystalloids. And critically, perform and document regular eye checks maybe every 20 minutes, just ensuring there's no direct pressure on the orbits.
Okay, let's move to those really acute systemic complications that can arise unexpectedly, starting with fat embolism syndrome, FES.
FES is a specific risk associated with fractures of long bones like the femur or the pelvis.
Right.
Also seen after joint replacement, THA, TKA, and any procedure involving reaming inside the bone marrow cavity. It's important to note, fat emboli themselves are probably quite common after these injuries or procedures, but the actual syndrome, FES, is much rarer, but potentially lethal.
There's a classic clinical triad for FES, isn't there?
Yes. Hypoxemia, low blood oxygen, typically a PO2 below 60, altered mental status, confusion, drowsiness, coma, and a characteristic petechial rash.
Tell us about that rash. It has a peculiar distribution.
It does. The tiny red or purple spots, the petechiae, typically appear on the non-dependent areas of the body, the chest, neck, armpits, maybe the conjunctiva of the eyes, but often not on the back or legs if the patient has been lying supine.
Why that pattern?
It's thought to be because fat is lighter than blood. The fat globules released into the circulation float upwards. In a supine patient, they rise to the top of the aortic arch and then preferentially embolize through the arteries, supplying the upper body and head. It's like an oil slick heading north.
What's the underlying cause? Is it just the fat blocking blood vessels?
There's debate. The mechanical hypothesis says yes, it's physical blockage by fat globules and marrow debris, but the biochemical hypothesis suggests that enzymes break down the fat into toxic free fatty acids, which then cause a massive inflammatory injury, particularly in the lungs. It's likely a combination of both blockage and inflammation.
And the treatment?
Unfortunately, it's entirely supportive. Oxygen, ventilation if needed, maintaining hemodynamics. There's no specific treatment to reverse FES and no proven way to prevent it definitively, although careful surgical technique might help. Importantly, both general and regional anesthesia are considered equally safe in patients at risk.
The other major acute catastrophe is acute compartment syndrome, ACS.
ACS is a surgical emergency. It happens when pressure builds up within a closed muscle compartment, usually in the limbs, surrounded by tight fascia to the point where it cuts off blood flow to the muscles and nerves inside. This risks tissue death, nerve damage, even amputation if not treated quickly.
Most common cause.
About 2/3 of cases are related to fractures, especially fractures of the tibial shaft, the main shin bone. That compartment is notoriously tight.
Who's most at risk?
Young males, typically under 35. Probably because they tend to have larger muscle mass within those compartments, so swelling or bleeding causes the pressure to rise more quickly and severely.
The big diagnostic challenge is that the classic signs, the 5PS, pain, pallor, paresthesia, numbness, tingling, paralysis, pulselessness, are actually late signs, aren't they?
Very late signs. By the time you see pallor or lose the pulse, significant damage may have already occurred. The earliest and most reliable symptom is usually pain specifically, pain out of proportion to the apparent injury, or pain that increases with passive stretching of the muscles in that compartment.
And here's the critical link to anesthesia. Regional blocks, or even just strong opioid analgesia, can mask that crucial early pain signal.
Exactly. An effective block can make the patient comfortable, but it might hide the development of ACS until it's much further advanced. This is why vigilance is so important, especially in high-risk injuries.
So if you suspect ACS, or in an unconscious patient who can't report pain, you need objective measurement.
Yes, direct measurement of the pressure inside the compartment using a needle and transducer is the definitive diagnosis.
And how do you interpret that pressure? Is there a magic number?
It's not just about the absolute compartment pressure, because that needs to be considered relative to the patient's blood pressure, the pressure perfusing the limb. The key value is the delta P. That's calculated as the patient's diastolic blood pressure, DBP, minus the measured compartment pressure, CP.
Why diastolic?
Diastolic pressure represents the lowest pressure driving blood flow into the capillaries during the cardiac cycle. If the compartment pressure gets too close to the diastolic pressure, perfusion stops. A delta P of less than 30 millimeter Hg, sustained for more than maybe 2 hours, is generally considered an indication for emergency surgery.
And that surgery is?
Fasciotomy. All the tight fascial compartments involved must be surgically opened along their entire length to release the pressure, and those wounds need to be left open initially, usually for 48 hours or more, to allow swelling to resolve before closure is attempted. It's limb-saving, but requires immediate action.
Okay, let's finish by looking at some specific tools we use, pharmacologic and mechanical, to manage risk and improve safety, starting with the pneumatic tourniquet.
Tourniquets are essential for many extremity surgeries, giving that bloodless field, but they definitely have risks. Basic safety, limit inflation time, ideally under 2 hours, use proper padding, use the widest cuff possible to occlude flow at the lowest effective pressure.
But they cause pain even with regional anesthesia sometimes. Why is that?
That characteristic tourniquet pain, the dull, aching, burning sensation that starts maybe 45, 60 minutes after inflation, is thought to be transmitted mainly by unmyelinated C fibers. These C fibers are more resistant to local anesthetics than the faster myelinated A delta fibers that carry sharp pain. So even with a good block, that slow, dull C fiber pain can eventually break through.
And what happens when you let the tourniquet down? The deflation syndrome.
Right. When flow returns, all the metabolic byproducts that built up in the limb, lactic acid, potassium, CO2, get flushed into the systemic circulation all at once. This causes a transient metabolic acidosis, a temporary rise in serum potassium, hyperkalemia, and some cardiovascular effects. Typically a brief drop in blood pressure and vascular resistance, and a noticeable rise in end-tidal CO2. Usually resolves quickly, but you need to anticipate it.
Let's talk drugs. Tranexamic acid, TXA. It's become almost standard in joint replacement for bleeding management. How does it work?
TXA is a synthetic amino acid, an analog of lysine. It works by competitively blocking the sites on plasminogen, where activators normally bind. By preventing plasminogen from being converted to plasmin, it stops the breakdown of fibrin clots. So it stabilizes existing clots and reduces bleeding. It's much more potent than older drugs like EACA.
The benefit is obvious. Less blood loss, fewer transfusions. But there used to be concerns about using it in patients with a history of clots, right? VTE, stroke, heart attack.
That was the traditional teaching, yes. A theoretical concern about increasing the risk of thrombosis. However, a lot of recent evidence, particularly from large orthopedic trials, suggests this concern might be overstated. Studies now indicate that using TXA in major joint replacement, even in patients considered higher risk for VTE, doesn't seem to significantly increase the rate of thromboembolic events. Clinical judgment is still needed for individual patients, but the practice has definitely shifted towards wider use.
Is there a specific toxicity sign we need to know about, something unique to TXA?
Yes, a really interesting one. TXA is generally contraindicated in patients with severe color blindness. Why? Because changes in vision, either acuity or color perception, are considered potential signs of TXA toxicity. If a patient can't discern colors accurately, you lose that potential monitoring parameter during postoperative eye exams.
And timing of administration.
It varies a bit by procedure and surgeon preference. For THA, often given 5-20 minutes before the incision. For TKA, sometimes given 5-20 minutes before tourniquet deflation or just before wound closure.
Okay, last topic. Those sudden drops in heart rate and blood pressure, hypertensive bradycardic episodes, HBEs especially during shoulder surgery in the beach chair position. Why do these happen so often?
The incidence can be surprisingly high, maybe up to 30% in some studies, especially if an interscaling block is the primary anesthetic and the patient is sitting upright. The underlying mechanism is thought to involve the basal gyrus reflex, or BJR.
Explain the BJR. How does sitting up trigger it?
When the patient sits bolt upright, gravity causes significant pooling of blood in the legs and abdomen. This sharply reduces venous return to the heart. The heart chambers, particularly the ventricle, suddenly find themselves underfilled but may contract vigorously against this low volume. This specific state, a hypercontractile but underloaded ventricle, is thought to activate stretch receptors, mechanoreceptors, in the heart wall. These receptors then send signals via the vagus nerve.
And the vagal responses.
Paradoxical and profound. Instead of speeding up to compensate for low volume, the vagus nerve causes profound bradycardia, slowing of the heart rate, and vasodilation, widening of blood vessels. The body essentially slams on the brakes, trying to allow the heart more time to fill. But this happens at the cost of systemic blood pressure and cerebral perfusion. It can lead to severe hypotension, syncope, even a systole in extreme cases.
So preventing it involves trying to stop that initial trigger, the venous pooling and underfilled heart.
Exactly. Prophylactic measures include aggressive fluid loading before positioning the patient upright, using support stockings or sequential compression devices on the legs to minimize pooling, and some people advocate avoiding epinephrine in the local anesthetic used for the interscalum block.
Why avoid epinephrine?
The concern is that the beta agonist effects of epinephrine might exacerbate that cardiac hypercontractility when the heart is underfilled, potentially making the BJR more likely to trigger. Careful fluid management and vigilance are key.
Wow. We have covered an incredible amount of ground today. We've gone from the sheer volume driving orthopedic surgery through the complexities of OA, RA, AS, and frailty.
Dived into the specific risks of procedures like arthroscopy, arthroplasty with BCIS, the dangers of positioning in spine surgery leading to POBL.
Tackled catastrophic systemic issues like FES and ACS, and looked at the tools we use like tourniquets and TXA, and reflexes like the BJR. It really emphasizes the depth of knowledge needed.
Absolutely. Mastery in this field isn't just about knowing procedures or drugs. It's about that predictive vigilance, understanding how the patient's condition, the surgery, the positioning all interact, and anticipating where things could go wrong.
Right. And it strikes me that even with all the amazing technology and pharmacology targeted blocks, drugs like TXA, sometimes the difference between smooth sailing and disaster comes down to understanding these really fundamental physiological reflexes, like the BJR, or just ensuring adequate perfusion pressure to the brain or optic nerve.
It often does. The basics remain paramount.
So the challenge we want to leave you, the listener, with is this. We're getting better at managing the known mechanical and physiological risks. But what's the next big challenge? What's the hidden reflex, the subtle inflammatory pathway, the next physiological blind spot that modern orthopedic anesthesia needs to conquer to push safety even further?
That's the question. Where does the next leap in understanding and mastery lie? Something to think about.